Today, the American Journal of Managed Care is speaking with two experts to discuss the root causes of racial inequities in cancer care. Dr. John Carpten, professor at the University of Southern California Keck School of Medicine, outlines what needs to happen to improve cancer outcomes for minority populations and support minority scientists. And Dr. Russell Ledet, president of the 15 White Coats and medical student at Tulane University School of Medicine, explains the steps to breaking down the barriers to medical school for those from marginalized communities. Welcome. Can you introduce yourself and tell us about your work?
Hi, my name is John Carpten. I'm professor and chair, the USC Department of Translational Genomics. I'm also program co-leader for the Norris Comprehensive Cancer Center Translational and Clinical Sciences program. My research interests primarily center around human genetics and genome science. Throughout my career, I've had a strong focus in the area of cancer research, including cancer genomics, cancer cell biology, precision oncology, and I've also spent a large portion of my career trying to understand what we tend to consider or call cancer disparities, which are cancers that disproportionately affect underrepresented minorities and the medically underserved.
Right. What are some root causes of racial inequities in cancer care?
Some of the root causes of inequities in cancer care, when we look at underrepresented minorities and medically underserved, tend to sort of center around socioeconomics and limitations and access to quality health care. A lot of this, of course, is due to systematic racism, which has sort of created this built environment, that many individuals, particularly those from underrepresented communities, reside within. Where there's limited access to quality care, there's no strong focus on actual health care itself, on being a healthy individual, right? When we think about access to detrimental environmental factors, you think about certain areas where you see a significant increase in signs for cigarette smoking, signs for alcohol, and so this built environment that many individuals live in contributes significantly to these inequities that we see in healthcare, particularly cancer care. Of course, the financial issues, financial toxicities. When we think about something like cancer care, it can be typically really expensive, and so when we think about access to the best diagnostic methods, the best treatment options, right? In many cases, those things are dictated by access to private insurance, or access to specific types of insurance, or access to significant financial resources, which we know in many cases are not in alignment with these communities and these populations. So a lot of this is socioeconomics, financial issues, financial toxicities. And then I think, of course, a lot of this is brought about through just sort of overall systemic racism and social injustices in America. I think, we should also consider additional issues when we think about, these sort of inequities that we see, that again are just related to aspects, just the overall systematic limitation, right, in resources, right? Overall resources in general play a huge role. Now, I think, we can also point to policy, right? And the lack of push towards policies that will sort of lead to improvements in these environments and in these communities, which could then perhaps turn the table and provide individuals with the type of health care that they deserve as citizens of this country.
How do racial inequities in research lead to disparities in cancer outcomes and mortality?
So racial inequities in cancer research, right, also contribute to some of the differences we see in incidence and outcomes when we think about cancer and we think about cancer disparities. Um, I think there are a number of things that we can point to. I think one is sort of this whole issue with lack of diversity in clinical trials, and I think that's one place where we can start, where many of the therapies that are developed, whether they're therapeutic modalities that are based on sort of improving standard of care in combinations with chemotherapy, or whether they're clinical trials to test some of the latest and greatest types of cancer therapies. In many cases, we know, throughout the continuum of clinical development, from the model systems that are used to, for early testing of these agents in animal systems, the actual tumors that are growing in the mice, right, are typically not derived from a diverse collection of individuals. Most of the tumors are going to be derived from individuals of largely European descent. And then we move on to phase 1 clinical trials, which are small trials, typically, that are in most cases going to take place at, within cancer centers, academic medical centers. And in many cases, the patient populations there are just not diverse at all. And then, of course, when we move on to the phase 2 and the phase 3, the larger trials, those trials that actually are going to be those definitive clinical trials that are going to lead to an FDA approval. We know that, particularly when we look in cancer, the overall numbers of underrepresented minorities in those trials is infinitesimal. And this is even for cancers that have known disparities in incidence and outcomes, prostate cancer, triple negative breast cancer, colorectal cancer. We see typically numbers below 5% and sometimes below 3% in terms of the minority individuals that make up the clinical trial cohorts. So I think that's one of the big problems. And just to expand on that just a little, I think we don't necessarily have to look at it as, oh, we want to diversify the trials just because we want more minorities. I think we have to look at it from the standpoint that by diversifying the cohort, we learn more about the efficacy of the therapy, right? Or perhaps the toxicity profile. We shouldn't have to wait until the drug is approved and then used in practice to say, oh, we see a difference in sort of toxicity profile, or we see a difference in the effect of this drug across different populations. That should be built into the trials. And from my perspective, by diversifying trials, we help everyone, right? It's not just diversifying trials just so that we can potentially help individuals from these underrepresented minority populations, but by studying a sort of broader group of patients from the standpoint of populations, communities, perhaps we gain a broader breadth and depth of the activity of that therapy when it's being used to treat patients with cancer. So I think that whole concept of lack of diversity in clinical trials is one of the things I think that hampers our ability to really eliminate and deal with some of these disparities. I think the same thing can be said for the tools and the reagents that we use in biomedical research to understand the biology of cancer, right? Again, going back to some of the comments I made about clinical trials, the model systems that we use, the cell lines that we use in many cases are cell lines that are not diverse. They weren't derived from individuals from diverse backgrounds. So the understanding of the biology of cancer tends to be derived, right, from a relatively homogeneous set of reagents. And so, expanding the diversity right? And the biological reagents that we use for cancer research, again, could broaden our understanding of cancer and get us away from this concept of generalization. If whatever we understand here is going to generalize over here, and that may not necessarily always be the case. I think we also see this in, for instance, large, of course, I have a tremendous amount of interest in cancer genomics and genome science. And so one of the other things we know is that many of the large genetic and genomic studies that have been performed to try to understand the genomic sort of alterations and changes that occur in cancer, many of the tumors, again, were derived from largely European individuals. And we know that the diversity in those biomedical research cohorts is also significantly limited. Again, even when we think about tumor types that disproportionately affect African Americans, Black and Brown people, Hispanic Latinos, and so on and so forth. So I think thinking about clinical trials, thinking about these research reagents, and then finally, the workforce, right? We know that there has been, a significant limitation in the numbers of underrepresented minority faculty members, right, at large academic medical centers where a lot of the healthcare innovation occurs, right? And then we can continue to move back in the sort of the career path trajectory as we go back to the early stage scientists, the postdoctoral fellows, the graduate students, undergrads, and then even high school students, right, who have access to, internships in STEM related fields. We know that there are disparities there. So if we don't break down those barriers, we'll continue to have this relatively homogeneous, relatively a non-diverse workforce. And so that also plays a huge role in the disparities. And I think that we can point to a number of areas where that could impact. But, when we think about things like having access to, for instance, patient navigators, or having access to individuals who work in the healthcare system who can help provide and communicate, right, most effectively with patients, to educate them, to help them better understand their particular medical issue, can better help them better understand, their diagnosis or the various treatment options. So because we have this sort of limited diverse, so we have this workforce that's relatively homogeneous, and we really need to do a better job of diversifying our workforce.
Right.
So all of these things, I believe, play a significant role in cancer disparities.
Are there any other things that need to happen to improve cancer outcomes for minority populations?
Well, I think, one of the main things, and, without a doubt, even though, my focus is biology and trying to understand the biological factors, right, that are driving these disparities. I think it all starts with policy. It all starts with sort of resources and access to resources, right, and equal access to resources. And so, of course, we have to get out and vote. We have to, we have to lobby our congressmen. We have to work with patient advocates, right, who have relationships with those individuals who actually can create and change policy. I think that to me is first and foremost. I think going back to the whole concept of doing a better job of diversifying the workforce, I think that's another huge issue. When we look back over time, we've made some progress, but the progress definitely hasn't been substantial enough where we can really say that we've made a significant difference. But policy is a big deal. I think one of the other things is bridging disciplines. So bringing together individuals from various disciplines and creating transdisciplinary and multidisciplinary research programs where we bring in individuals who study the environmental factors, individuals who study social stressors in the built environment, and how the environment, right, and the pressures, right, the societal pressures, can impact physiology in a negative way, such that it sort of breeds an internal host environment that if a cancer manifests, right, it's in the perfect environment to thrive, right? And so I think the whole concept of interdisciplinary and transdisciplinary research will probably be part of the answer. And we have to break down the barriers, break down the walls, and break down the silos, and begin to work together and come up with novel study designs, again, that bring to bear various disciplines to address these issues.
Right. What specifically can cancer research centers do to support the needs of minority scientists?
So one of the biggest issues in terms of cancer centers and minority scientists is that there just aren't enough of us. I think we can look at this in two ways. We can look at it from the standpoint of the pipeline, right, and really working harder to increase the size of that pipeline. Providing the types of educational programs for underrepresented minority students to get access to innovation, right? To be involved in innovation, to be a part of innovation, and not doing it. And I think one of the problems is when we see many of these programs, in many cases, the students are separated, right? You may have a special program for underrepresented minority students, but you don't have, mainstream students involved, right? So we tend to see these siloed programs. I think we need to develop programs where the students are all working together and learning how to collaborate and how to communicate with each other, and how to come up with innovative and novel ideas on how to solve problems. So I think, coming up with better ways to build a more robust and effective pipeline, so that we can feed the students into the process. But I think we also have to look at the back end, right, of the pipeline when the students become graduate students and then postdoctoral fellows or faculty members, that we provide the type of environment to support their career development, again, at the fellowship level as well as at the faculty level. That they have the appropriate mentoring in place, that they have the appropriate role models in place, that resources are available for them to support their careers. So we have to work on building a more robust pipeline, but at the same time, we have to ensure that the appropriate environments are being created in those cancer centers to support retention, right, of the faculty that we hope to recruit into these centers.
Can you introduce yourself and tell us about your work?
Yes. So my name is Dr. Russell Joseph Ledet. I'm currently the president and co-founder of the 15 White Coats. And I'm also a third-year MD, MBA student at Tulane University School of Medicine and Freeman School of Business, respectively. I live here in New Orleans with my wife and 2 children.
Great. Can you tell us about how the 15 White Coats evolved from a photo into an organization with a larger mission?
So basically, the 15 White Coats was formed after a very unique experience happened between my daughter and I. So essentially last summer, my very best friend came down to visit me from New York. He and I are getting our PhD. He was getting his PhD out of the same lab as I. And so we both went to historically Black colleges and universities. He went to North Carolina A&T, and I went to Southern University in Baton Rouge, Louisiana. And so Black history is important to us. And so when he came down to visit, we decided to go to the Whitney plantation, and I brought my daughter along. And It's about 45 minutes outside of New Orleans. So on our ride back, about 15 minutes down the road, my daughter sort of interrupted me and asked this question. She was just like, she was essentially like, Dad, you know, it's interesting that we just left a plantation and, you know, I'm riding in the car with two, you know, Black doctors. And I'm like, well, why is that such a big deal? And she's like, well, just think about it. Like there was a time when we couldn't do that. There was a time when we couldn't, you know, be lawyers, accountants, firefighters, any of those things, right? So she really understood the moment and also the historical context. And so essentially from that, I looked over at Phil and I was like, yo, I got an idea. I was like, I think we should get together a couple of my Black classmates and we should go and take a photo. Obviously there was more to it than us just taking a photo. There was also the experience itself, right? And so, you know, after we had this experience and we took these photos, the idea behind the photos was for us to caption just how far we've come. And even more so our resilience with that, you know, with coming back from that. And so we released those photos. Those photos got a ton of attention. And because of that, we realized that we had an opportunity to leverage that attention for good. And so because of that, we formed the company. And the idea behind the company was to promote cultural imagery and learning spaces, because we realized like it's kind of hard to be something that you've never seen before, right? Like that's half the challenge. And the other part is too, is that it was kind of like a, you know, we'll get past these issues anyway. Like we'll get past these circumstances, the systemic racism, the institutional racism, systemic oppression. Like we'll get past it anyway, and we'll still get to where we want to be. Because I mean, everyone's knowledgeable of the esteem doctors are held to in the United States specifically. And so I think that's where it really captivates a lot of people's attention, is that they saw 15, you know, budding, bright-minded, you know, student physicians, and they just so also happen to be Black. So that was really captivating for a lot of people. And because of that, we formed the organization. We put the photo up in classrooms around the country. We sell the photos, and we take all. Nobody earns any money from the proceeds. We take all of it and put it towards scholarships for minorities applying to medical school, high schools, students graduating high school, medical students. And we also use the money, obviously, to buy more posters to send out to classrooms. So schools can go to our website, sign up for a poster, and we'll mail it out to them for free.
Great. So what are your hopes for the organization?
Yeah, so the hopes for the organization is for us to eventually be able to pay for someone's medical school, specifically someone from the minority community, to raise enough money to offset some of the costs that come with applying to medical school. You know, if you take into account the historical economic perspective for marginalized communities, right? We know that those communities are well behind in terms of opportunity to gain wealth, opportunity to maintain wealth, you know, especially with things like the Tulsa, Oklahoma massacre and things of that nature. We know of all the situations in which, even when marginalized communities tried to gain wealth, it was stifled. So we have to do something to try to offset that economic barrier. People don't even know how much it costs to apply to medical school. In general, it costs between $3,500 and $10,000. That's a lot of money just to apply. So if you take that into account, right, and then you take into account a lot of these students already in debt from undergrad, where are they gonna come up with that kind of money from? You know, and so we want to try to take some of the money that we have and alleviate some of those costs. And then, you know, the other part of it is too is that once you get into medical school, there are a lot of costs that come with being in medical school, whether it be some of the learning platforms you need in order to learn the material you need for school, or, having professional attire, living costs, all these things. And so that's really our hope, is to try to offset some of the economic burden, specifically for marginalized communities, when it comes down to the medical school process.
Great. What's the importance of representation in the media for young Black children and teens, especially in a field like medicine?
Yeah, I think the importance of representation is multi-pronged, obviously. I think if you think about it just from a visual perspective, the reason why a lot of people, especially, Black men, can aspire to be great basketball players is because we've had so many Black great basketball players. If we never saw them, it'd be kind of hard for us to imagine it, right? It's the same thing in medicine. We need to see representation in order for us to see that it's even possible. I'll never forget, I had this one experience. I was shadowing a child psychiatrist, and he went to go get a patient, which was a young African-American boy. And when the young boy walked into the room, his eyes just lit up. It's like I don't know, it's like he saw Jesus or something. And he sat down, and I knew why he was looking at me like that, because he probably had never seen, a Black male who looks like me, with the hair, the beard, and a white coat on, sitting in the room. Almost as if to say, like, do you belong here? Like, are you supposed to be here? Is it okay for you to be here? And I finally got an opportunity to talk to him, and he just was like, he poured out his life in front of me. And so I think that representation goes far, just from a visual perspective, but I think there's an underlying experiential perspective. We know that representation matters in terms of, how the doctor's visit will go, because of the cultural understanding that is very possible in an environment where there is some sort of congruency in experiences as well as a culture. So that's not a secret. And then more so, I think, if you take into account the history of medicine in marginalized communities, it's not pretty, right? I think her name was Harriet, maybe Washington, I think her name is, wrote the book, The Medical Apartheid. And she talked about the atrocities that have happened for a lot of medicine to progress. And now this was done on the backs of a lot of Black people. A lot of the experiments, a lot of these, falsehoods that are out there, that Black people experience less pain. The experimentation that's been done on Black folks for, eons of time, have contributed to some mistrust, right? And so how do we try to overcome that, or at least to some degree try to fix it? You got to have some people who understand the history, some people who understand the culture, but also some people who have come from those communities providing care, because they know their people. They do. They genuinely do. And so accessibility in the medical school will help with that. And also accessibility when it comes to positions of influence and power within medical schools, within academia, within, hospital systems. It's not just medical school. It's got to be institutional change at a lot of different levels. Obviously, with me being in med school, my interest right now is med school, but I'm certain that will change over time and it will expand.
So what needs to happen in order to change, to break down these barriers to medical school?
Right. So I think there are a couple things that need to happen for accessibility to medical school. I think you need to get some different people selecting who goes to med school. I think you have to get some people in the room who value people from minority communities as people. And not just because they're trying to fill a quota, but because they genuinely value their culture, their experiences, what they bring to the table. And they're willing to institute anti-racist policies that kind of go against what's been done for a long time. Right. And I always say this because we, like, as a human race, we have accomplished some very, lofty feats. Some very lofty goals, like sequencing the human genome, identifying PDL1 as as therapeutic targets for cancer. We've done a number of things that were absolutely incredible and pushed humanity forward. I think we can achieve true diversity and inclusion, because we can't forget about the inclusive piece, by relearning a lot of things, unlearning some things that we've utilized as status quo for how we go about selecting people for medical school, but also learning new ways to value people as people. And I talk about this inclusive piece because, it's no point in you recruiting me if you're not going to include me. So if you're going to bring me to your building, but then it's clear that I'm not welcome, but you're kind of doing it to check a box, I mean, am I really going to want to stay there? And even if I get through, am I really going to want to contribute afterwards? Most likely not. I mean, and so I think another big piece to changing the paradigm is changing the culture. I think it says something that a lot of faculties in general may have one or two, Black people on the faculty. That's not good. Like that's just fundamentally not good. If you're graduating a lot of Black medical students, don't you think you should have more Black faculty? Right? I mean, you're producing doctors. They should be like, you should be getting them back, or you should be getting some from somewhere. And so that speaks to culture. I heard Roland Martin talk about something similar to that this morning with ABC, and one of their issues was it was a culture problem. And I will say that there is some cultural issues in medical school around there not being enough anti-racism being taught. So I think that'll help. Definitely the economic piece. Definitely getting the right people in the room to choose who should be in a medical school class. And lastly, the culture. The culture needs to be overhauled, not just fixed. It needs to be overhauled. We need to be teaching. We need to be teaching about medical apartheid and the history of how obstetrics and gynecology move forward, how pain management move forward. How all these different fields, how surgery moves forward, and the ugly history behind it. Because if you aren't teaching doctors that, or if you aren't teaching student physicians that, then when are they going to learn it? When they get into their specialty? No, they'll be too busy. So you got to teach it to them at the foundation of their medical school education.
Right. That's the end of my questions. Was there anything else you wanted to add?
If you want to check out the 15 White Coats, you can check us out on Instagram, Twitter, or Facebook at the THE15 White Coats, or you can check out our website, the15whitecoats.org, and we'll always speak truth to power.
Great. Thanks so much for taking the time to speak with us. Really appreciate it.
Yeah, no problem at all.